Dear colleagues, ladies and gentlemen, on behalf of the task force, it is my pleasure to show you the recommendations on DAPT type and duration in ACS patients. These are my declarations of interest. In my talk, I will focus on the choice of P2Y12 inhibitor, on pretreatment, on the duration of dual antiplatelet therapy after PCI, and then briefly on the duration in medically managed patients. So let's look first at the choice of P2Y12 inhibitor. The current recommendations are mainly based on Triton and Plato, two studies with a different study design, and this impacts on the recommendations. Both included ST elevation myocardial infarction or high-risk non-ST elevation acute coronary syndromes. Triton included only P2Y12 inhibitor naive patients with planned PCI or known eligibility for PCI, whereas in Plato, any treatment strategy was allowed and patients could be included irrespective of previous P2Y12 inhibitor use. Let's look at the benefit of ticagrelor and prasugrel in ACS. Let's first look at Triton. Here you can see that in Triton there was a 2.2% reduction in death, MI and stroke at the expense of an 0.6% increase in TIMI major bleeding, with numbers needed to treat of 46 and numbers needed to harm of 167. So a very favorable risk-benefit ratio. And in Plato, with the same endpoints, we obtain very similar results. So again, a very favorable risk-benefit ratio. So the recommendations are quite clear. Ticagrelor on top of aspirin is recommended regardless of the initial treatment strategy, including patients pre-treated with clopidogrel. And prasugrel on top of aspirin is recommended for P2Y12 inhibitor naive patients with non-ST elevation acute coronary syndromes, or initially conservatively managed STEMI if indication for PCI is established, or in STEMI patients undergoing immediate coronary catheterization. These are more or less the same as in previous guidelines. Now let's look at pretreatment. A couple of years ago we had a very elegant meta-analysis by Bellarmine-Appé from the Paris group, and she could show that there was benefit of preloading with clopidogrel, and you can see that there was a non-significant reduction in death, a non-significant increase in major bleeding, but a significant and a clinically relevant reduction in major coronary events. If you now focus on the clinical setting where this benefit was gained, you can see that the reduction of major coronary events was seen in non-ST elevation ACS patients and in STEMI patients, whereas the impact of bleeding was largely independent of the clinical presentation. So a particularly favorable risk-benefit ratio for clopidogrel in the setting of acute coronary syndromes. Now we have learned, of course, that we shouldn't use clopidogrel in this setting, but prasugrel or ticagrelor. So what's the data for these drugs? A COAST looked at non-ST elevation ACS with unknown coronary anatomy and showed no benefit of preloading with prasugrel. Here you can see that the curves are virtually superimposable. On the other hand, there was more bleeding with, after preloading with prasugrel, and this was statistically highly significant and clinically relevant. Atlantic looked at preloading with ticagrelor in STEMI, and there was no benefit or harm. You can see that the co-primary endpoint, ST resolution before PCI and TIMI grade 3 flow before PCI were almost equal, but there was also no significant or no difference in TIMI major bleed and also in other important clinical endpoints. But this is not the end of the story. We have to keep in mind that in Triton, few patients did in fact have pretreatment, and these were the patients with known coronary anatomy or with ST elevation myocardial infarction, and the outcome in these patients was very similar to the overall cohort, and it contributed to the overall benefit of prasugrel over clopidogrel. In Plato, there was even systematic pretreatment at a median of 4 hours in non-ST elevation ACS and very short 15 minutes in STEMI. And again, this pretreatment was part of the benefit seen of ticagrelor over clopidogrel. So we end up with these recommendations. Pretreatment with a P2Y12 inhibitor is generally recommended in patients in whom coronary anatomy is known and the decision to proceed to PCI is made, as well as in patients with STEMI. In patients with non-ST elevation ACS undergoing invasive management, ticagrelor administration or clopidogrel, if ticagrelor is not an option, should be considered as soon as the diagnosis is established. And in non-ST elevation ACS in whom coronary anatomy is not known, it is not recommended to administer prasugrel. The first two recommendations are new. Now let's look at duration after PCI. And before we do this, we should keep in mind that both bleeding and infarction have a similar prognostic impact. And you can see that on average, a bleeding event or myocardial infarction increases the risk of subsequent death during 1 year follow-up by about threefold. But the impact of bleeding on outcome is independent of the timing of the bleeding event, whereas myocardial infarction has a larger impact if it occurs early during the course of the disease than if it occurs late during the course of the disease. Now, how does this apply to the interpretation of the data? Let's first look at Triton and Plato, and here you can see a substantial increasing benefit with both agents, prasugrel and ticagrelor over clopidogrel, as time goes by for the first year for the duration of the study, and clearly this establishes a 1 year treatment. And you have already seen the favorable risk-benefit ratio in this setting. Now, with the curves separating, the question is reasonable, will their curves continue to separate? And this was addressed in the Pegasus trial. In Pegasus, patients 1 year after myocardial infarction could be included, and they were randomly assigned to placebo on top of aspirin or ticagrelor on top of aspirin. And here you can see that during 3-year follow-up, there was continuous separation of the event curves with continuous benefit of dual antiplatelet therapy over single antiplatelet therapy with aspirin. And you can see that this difference was statistically highly significant. However, there was an almost a very similar increase in TIMI major bleeding at the same time. And from what I've shown you before, you wouldn't be surprised that there was no difference in all-cause death in the Plato trial. We also have data on prolonged DAPT after myocardial infarction from the DAPT trial, and this is the subgroup analysis, and you can see that the risk reduction for major adverse cardiac and cardiovascular events in patients with previous myocardial infarction in the DAPT trial was even larger than in patients without previous myocardial infarction. Also, for stent thrombosis, there was a very consistent reduction by prolonged antiplatelet therapy with gastro-bleeding, no significant interaction, maybe numerically a little higher risk in patients with previous myocardial infarction, but no significant impact on all-cause death. Udell and co-workers analyzed all the data that we have on prolonged antiplatelet therapy after myocardial infarction, and they found a significant, statistically highly significant decrease in MACE with an absolute risk difference of 1.09% at the expense of a highly significant increase in major bleeding of 0.76% with no significant difference in all-cause death. Now, with this almost equivocal benefit-risk ratio, we need to go for individualized treatment decisions. And lucky enough for personalized stratification of DAPT duration, we have evidence-based score systems. And here I'm showing the DAPT score. You have seen it in the presentation of Hector Bueno. And if the DAPT score is below 2, then we have a significant increase of bleeding events by prolonged dual antiplatelet therapy with no benefit in terms of ischemic events. However, if DAPT score is 2 or above, then you have a significant and relevant reduction in ischemic events without any significant increase in bleeding events. We also have the precise DAPT score, which was also externally validated, and it also allows a personalized stratification of DAPT duration, and it was divided into quartiles of very low, low, moderate and high DAPT score. And you can see that if the precise DAPT score is above 25 or equal or above 25, i.e. in the high range, then you have a significant increase in bleeding events and no benefit with respect to ischemic events. Even the ischemic events are numerically higher with prolonged DAPT. However, if you are in the moderate range, then you have a significant reduction in ischemic events without a significant increase in bleeding events. If the precise DAPT score is very low or low, event rates are low and there is no significant effect either way. Now with these evidence, we end up with the following recommendations. In patients with ACS treated with coronary stent implantation, DAPT with a P2Y12 inhibitor on top of aspirin is recommended for 12 months unless there are contraindications such as excessive risk of bleeding. In patients with ACS and stent implantation who are at high risk of bleeding, discontinuation of P2Y12 inhibitor after 6 months should be considered. In patients with ACS who have tolerated DAPT without a bleeding complication, continuation of DAPT for longer than 12 months may be considered. And in patients with myocardial infarction and high risk who have tolerated DAPT without a bleeding complication, ticagrelor for longer than 12 months on top of aspirin may be preferred over clopidogrel or prasugrel. All of these recommendations are either updated or new. Let's briefly look at duration in medically managed patients. This is only a niche indications because according to current guidelines, very few patients should fall into this category. The recommendation is also 12 months DAPT as a general rule based on Cure and Plato. Ticagrelor is preferred based on Plato. Prasugrel is discouraged because there was no benefit over clopidogrel in the Trilogy trial. At least 1 month for high bleeding risk in patients with high bleeding risk based on expert opinion, and as a possibility that may be considered beyond 1 year after myocardial infarction if well tolerated based on Pegasus. All of these recommendations are either updated or new. So let me summarize. In ACS patients undergoing PCI, if there is no high bleeding risk, then continue for 12 months, preferably with prasugrel or ticagrelor, and after 12 months we evaluate the patient, and based on an individual risk stratification, then you may continue with dual antiplatelet therapy, and the best data that we have in this setting is for ticagrelor. If there is high bleeding risk, then you should discontinue dual antiplatelet therapy after 6 months. For patients treated with medical treatment alone, if they are not at high bleeding risk, the duration of DAPT is the same as in patients with having undergone PCI. If there is a high bleeding risk, then do continue at least for 1 month, but then stop early. Thank you for your